Clinton, PGY3 in internal medicine, and this is a very important video, which is basically standing up for yourself as a medical resident is important, because when you leave things unsaid, which might be important, the way you amend these mistakes is by putting dirt on them. Basically, this patients can end up dead, can end up in the cemetery if you do not speak out. So there is a fine line between, of course, being respectful and saying your part and just being upfront disrespectful. So this is a fine balance which we all have to work on every single day of our life. We have to work on that emotional intelligence, on how to transmit information, and that you don't come off as someone who is just trying to make others feel bad. So it is difficult. I will definitely say that I come from a Latin American country in Costa Rica, and I already did residency over there. And when my residency experience and all my medical school, I was used to people just basically talking down on you and telling you in the face this and that, and this is how you do it, and why did you do this mistake and that mistake, and sometimes you didn't even make a mistake. So you had to build some character. Well, there's two options. One is just take it and just not say absolutely anything. But in my personal case, just taking it, I started doing this and I started accumulating and accumulating just like these negative feelings that would ultimately lead me into major depression. So I decided I won't do these things. Like, I don't have to take the blame for things I did not do. I have to figure out a way to express the reality of what I'm thinking, but but respectfully. So I tried doing these things, and early on in my career, several years ago, I lacked the emotional intelligence to be able to handle these situations, which are not easy at all. So that took me through some difficulties, and those difficulties, of course, were additional challenges that no one has to go through during a residency. Nowadays, I've worked and worked on these things, and I've actually focused on the psychological aspects, because I've seen that even if you're in a different context, in a different continent, Central America versus the US, and worlds apart healthcare systems, their structure and opportunities and all that, in the end, human beings act very, very similar, even being very culturally different. So that was caught my attention, and that has helped me also navigate through these different socializing encounters that we have to do on every single day in the hospital. Remember that only the pathologist doesn't have to socialize much with the other doctors, and the radiologist, now they're having to socialize more, because there's the interventional radiology, which you have to talk back and forth with them. But those are two specialties that don't have to be socializing much with you or the patient. Well, most of the medical specialties, you do have to work on that emotional intelligence. And yeah, so it's interesting how the human brain functions and how these social interactions just go. For example, in Costa Rica, people were more direct and would yell you in your face. You knew immediately who did not like you in Costa Rica, usually the grand majority of time. Here in the US, it's way more blurry lines, and it's way more politically correct, and there's a whole lot more backstabbing, I feel. There's people, if they don't like you, everyone will smile at you, and when you turn around, they'll be talking bad about you, and all of a sudden, 1 month later, someone might be talking about you. Hey, did you hear how Charles did this and that, and I don't think he did this correctly, this and that. And someone just tells you about it, and you're like, wow, this is crazy. I was with this person in the room. We discussed the what we were going to do next. They agreed upon it, and we went forward with it, and they're saying that thought I did something horrific, something bad. Like, this doesn't make any sense. So those things happen, and the only way to get out of these broken loops of communication is if you yourself practice the best communication you can. So you have to work on emotional intelligence. You have to be calm and collected. You have to be able to express your viewpoint, and also hear the other's viewpoint. And sometimes this is difficult, because sometimes people might take it personally against you, and you're just trying to help the patient. And maybe you go in to see, for example, you go in, you see a patient, it's a MET call, it's a rapid response call. You are the person, the doctor, MD, in charge of leading the rapid response team. You have a nurse, which is gonna go see the patient initially, and you have a respiratory therapist, which usually goes to see the patient initially, and of course this patient has been seen by a hospitalist or by some other MD. So you might go into the room, and when you go into the room, maybe the hospitalist was there, and they had come up with a plan with the MET team, and you arrive because you were doing a procedure, you were putting in an arterial line, and when you arrive, you ask them about the patient, and they might tell you this and that, and they might tell you this patient is, for example, bradycardic, and we gave him such medication, and what I think is that the patient has pulmonary embolism, so we will do a CT angiogram of the chest, and we will admit the patient to the ICU. And you think to yourself, like, wait a second, like, maybe this isn't PE or pulmonary embolism. This doesn't sound that clear to me. I have some questions. And why the bradycardia? Because if it's PE, I would expect more tachycardia. What are the risk factors for the PE? Why are we thinking it's a PE? Does this patient need the ICU right now, or this patient could actually go to stay here or go to intermediate care? Do we need the CT angio of the chest, or would that pose a risk to the patient? So all these things, and you get there as a resident. Remember, you are usually the weakest link So it's a weird situation because, yeah, you're a resident, you're information in your formation process, and you're the MD who is leading the rapid response team. But when you get to see the patient, you are having in front a hospitalist who is the main doctor for this patient who wants to do X thing, and at the same time you have your nurse and respiratory therapist, which might have been working in the hospital for maybe 10 years, and they think it should be done that way. So you have to deal with all these things, and you have to navigate through this. And if you just stay shut, it's going to be more problems, because if you stay shut and you just are like, okay, go ahead, let's do what do you want to do, let's just do all that, the patient can end up in a worse position. So if you, as the team leader, and in this difficult situation as a resident, because you're usually seen as like, yeah, the resident, you just, we understand you just have to come here, but we're gonna do this. Well, I'm not that person. I am the person in charge of the team. That means I have to know what we're going to do. I have to understand it, because this is a life at stake. So if I have to answer and I have to say like, wait a second, why do you want to do a CT angio chest? I will ask that, but I will have to ask it the most polite way I can, because in medicine there's a whole lot of gaslighting, there's a whole lot of sarcasm. It's very difficult. It's not like you're talking to someone in the park. We're talking very complex conversations here, because most doctors, at least in this area of the US that I've seen, no one says, I don't agree with this because of this. They don't even say that. They just say, oh, okay, yeah, okay, might be that, but I was thinking a little more along the line of such and such. And you can see, and you see the interaction finishes, and this doctor tells you, hey, that's incredible. How is that doctor saying X, Y, and Z? That is impossible. That doesn't make sense at all. And this same doctor had just told the other one, yeah, oh yeah, I see what you're getting at. Yeah, I think it could happen, but I'm thinking it might be more of this. You're not being truthful. So what happens is that you're generating a communication breach, and what is at stake is a life. So I would like to be a little more honest. We have to be more honest and truthful, because these are patients in the end. We have to be able to have these conversations, medical discussions, because they're important. So we have to be able to tell these people, when you go see this potential pulmonary embolism, you have to be able to say, okay, what's the story? Okay, why do we think this is pulmonary embolism? Okay, but I'm not sure, something isn't adding up. Do we have an EKG with right heart strain? No, there's no EKG. Let's get an EKG, please. And people look at you like, oh. Well, that's what we need to do. If we think it's a pulmonary embolism, what is our data? Remember that the most sensitive finding in pulmonary embolism is going to be tachycardia. If you don't have tachycardia, if you don't have right heart strain and the EKG, which of course its sensitivity isn't that much, but your patient is so unstable, you think this is massive pulmonary embolism, we have to have some information about it. And I personally do POCUS. I love doing POCUS. Here's my Vscan Air SL. And I went and did a POCUS on the patient. I didn't see any D shape. I didn't see septal flattening. I saw normal left ventricular ejection fraction and function, and the right ventricle no McConnell sign. So basically, I didn't see much telling me this is massive pulmonary embolism. What I thought this patient had was bradycardia, symptomatic bradycardia, because the patient, although they had a history of using metoprolol, it seemed like they had never picked it up. And now all of a sudden, of course, the home med was restarted, and now the patient was having symptomatic bradycardia events. Another thing the patient was also having was hyperkalemia, which was above 5.8. So those are differentials you have to rule out. So you give recommendations, you have to stand your ground, and the only way that you have to change your mind is if you're faced with objective data. If there's no objective data, why will you just give in to, yeah, let's take the patient to CT angio, and the patient is sort of still unstable? You have to be able to say, wait a second, I don't want to move this patient right now. Let's wait. Let's get his heart rate more stable. Let's do this. Let's do that. Right? Just an example. I'm combining some true factors or facts that happened recently with some additional information just to make this sound relatable. Right? It's not exactly what happened, but you get the point. I see so many doctors that are not advocating for the patient. If this was your father or mother, oh, there you would be saying something. There you would be figuring out how to communicate more assertively. But since it's not family members, we oftentimes are like, I'll just let it go. Like, I don't agree, but I'll let it go. I'll give you another example. What about doing procedures the patient doesn't even need? Putting in an arterial line that your attendant tells you, hey, can you go ahead and put in an arterial line for this patient? Because I'm not sure if the blood pressure cuff correlates with, I'm not sure. The patient is on norepinephrine 2 micrograms per minute, of course, very low dose, and the blood pressure cuff is reading 150 over 80. So most residents just say like, oh, okay. And they go and they do that, and they try to put in the line. They thrombose the radial artery. Then they're doing an ultrasound of the radial artery just because the artery is not working, has no flow. And they do all that, and they're not able to access there. Then they go to the other arm, and the patient is just laying there watching television, answering their questions, showing them they have completely normal perfusion of 2 micrograms per minute of norepinephrine. Why don't you just reach out to your attendant and tell them, hey, wait a second, do we really need the arterial line? I'm not arguing or anything. I want to understand why we do need an arterial line, because right now we have two admits, we have another procedure, and there's a patient that the med team is seeing that's unstable that I will have to go see soon. So is that something we really need right now? So that's a good question to ask. And the attendant will tell you, oh, okay, no, not now, maybe in 2 hours. Then you can ask, okay, and well, I also checked the blood pressure on the other upper extremity, and it's very similar. I checked the blood pressure on the lower extremities. It is very similar. The patient has normal urine output. The patient has a normal kidney function. The patient is alert oriented ×4, talking to me without any complaint. Can't we try to just go off the norepinephrine before putting in the arterial line and wait for an answer? Like, there are people that, even this that I'm saying, that a resident doesn't dare to do because he gets yelled at. If you get yelled at for this, just be in peace. You did what you had to do. Say it respectfully. And this is difficult. I will tell you that the way I have learned to do this the best is, and I note a very clear difference, is when I work out in the morning, my internal, like endorphins, natural endorphins are, and nothing moves me. So I can give this information calm, just objective, just don't take anything like personal, no ego battles, no this, no that. If I don't work out and I'm just tired and all this, and I have these ideas, sometimes I'm like, I don't think I might convey it in the best of ways. And sometimes I have to let it go, because if you can't convey this information with all the peace of mind, you can get into a battle, right? An ego battle, a unnecessary interaction. So those are my thoughts. I think I talked about a couple different things in this video. I'll just put on timestamps. See you in the next one. Give me your thoughts, opinions, and make yourself heard respectfully.